My name is Dr. Stephen Eric Finkelstein. I'm a radiation oncologist at Florida Cancer Affiliates at the U.S. Oncology Network. And I'm going to give you an update on new approaches combining brachytherapy with immunotherapy to treat prostate cancer. When we think of popular radiation therapy treatment options, we think of using linear accelerator-based radiation therapy or external beam radiation therapy by machines seen here on the left. That's a linear accelerator which creates megavoltage X-rays and can be used in therapies known as intensity modulated radiation therapy or stereotactic approaches such as stereotactic body radiation therapy or SBRT. Now that is different than some of the oldest way we've done radiation therapy, but still very, very effective, brachytherapy, which is seen on the right side of the screen. Indeed, brachytherapy has been around a long time and has been very effective for the treatment of cancer patients. It's in prostate cancer is done via a transperitoneal interstitial approach with permanent seeds being placed or potentially high dose rate treatment. But in this case, I'm showing you we're seeing a transperitoneal approach of which seeds are placed under ultrasound guidance to create a homogeneous dose of radiation being delivered into the prostate gland. When we talk about definitive prostate therapy, the comparative effectiveness, i.e. looking at relapse-free survival results, again, treatment options can be radical prostatectomy, either open or robotic, external beam approaches using IMRT or protons as therapy, and additionally, which slots in here, is brachytherapy. And the standard approach had been low-dose brachytherapy via seeds, and they can be tied together using a stranded approach. Additionally, there are other therapies such as cryotherapy or freezing. In a seminal paper done by Sylvester and Grimm, which was a comparative analysis of prostate-specific antigen-free survival outcomes in patients with both low, intermediate, and high prostate cancer treated by a variety of therapies. You can see here that when you compared external beam therapy as the circle in green as clustered outcomes, surgery as seen here clustered in red versus external beam therapy and seeds for the intermediate risk prostate cancer patient, the data that seemed to be the best with respect to treatment success as a percent of progression-free survival was external beam radiation therapy plus seeds. When we look and translate this, not intermediate risk patients, but in high risk patients, again, green, this circle cluster would represent external beam, red would represent surgery, external beam plus seeds would be the gray again, and then up here we see external beam plus LDR brachytherapy plus androgen deprivation. We can see again that the use of brachytherapy provided an excellent response with treatment success as percentage of PSA progression-free survival. Now, when we talk about cancer practice, it's a multifactorial issue, right? There are multiple cogwheels that help to illustrate this. And this is a slide that I was given by my friend Jason Evstafio at Harvard. So when we look at how well things are utilized within cancer care, it's a conglomeration of whether task force talk about it, the guidelines, how patients are being actually managed, the interaction with payers, what patients' ultimate preferences, ultimately some biases that fit in by both providers and by patients, whether people market some of these technologies, and ultimately with reimbursement. And we like to think it's all based on data, but it's probably more a conglomeration of some of these cogwheels that fits into the development of cancer practices that are effective and utilized. So when you look at the potential of applicators for additional therapeutic approaches, brachytherapy has a lot going for it. It uses precisely delivered radiation sources to treat cancer within patients. And the precise delivery of radiation sources is frequently accomplished by the placement of these small catheters in proximity to or around cancer tissue. The place that applicators have not been effectively used for applying additional therapeutic approaches, however, and this is where it's exciting undiscovered country. Now, indeed, immunotherapy has become a rapidly exciting approach that is an approach which is fundamentally make radiation, including brachytherapy radiation, relevant at a systemic level. Indeed, we've coined the term radiation-driven immunotherapy, and brachytherapy has an important part to this. So when considered in isolation, radiation to any particular cell could be anticipated to have a detrimental effect. However, the interplay of tumor cell death, androgen expression, inflammatory signals, lymphocyte and dendritic cell activation presents a unique therapeutic opportunity. This work that I had published in 2012 summarizes the interplay of dendritic cells and lymphocytes and tumor cells and stroma and endothelium. And when we think about this, together the whole therapeutic effect can exceed the sum of its parts and present the potential for improvement of immunotherapy effects arising in therapeutic tumor irradiation to generate immunologic-mediated, radiation-driven, personalized systemic therapy, also known as RDI or radiation-driven immunotherapy. Now, the fundamental mechanism of tumor control through radiotherapy is thought to be through the induction of double-stranded DNA damage in neoplastic cells. However, this is probably not a complete picture of the time course of cellular events within the tumor. In this work, of which I had pleasure of publishing with Bob Timmerman and Bill McBride and George Wilson, among others, we can see that the use of radiation can induce unique cellular expression of MHC class I molecules, adhesion molecules, co-stimulatory molecules, heat shock proteins, inflammatory mediators, immunomodulatory cytokines, and death receptors. Again, the potential of applicators to work with radiation therapy and systemic agents like immunotherapy is a very exciting idea. And unfortunately, until very recently, we didn't really have any catheters well suited for this. I was fortunate to work with colleagues, of which a US patent was granted on May 28th of 2019 of a catheter which could be utilized with systemic therapy. Indeed, this patent relates to the applicators and methods for administering therapeutic agents to cancerous tissue, of which the applicator could be used to both deliver radiation therapy and additional therapeutic agents to cancer tissues inside a patient. When we look at this, this is known as Immunocyte. An Immunocyte is a novel device for a localized administration of radiation therapy via brachytherapy approaches plus immunotherapy in cancer patients. This technology is a novel medical device designed for localized dual administration of both radiation therapy and immunotherapy for cancer treatment. Now, the radiation therapy is known to widely to use to kill tumor cells and stimulate anti-cancer immune responses in cancer patients, but it's not always effective as a single agent. Preclinical and clinical studies have shown that dual administration of both RT and immunotherapy could be more effective, but there's no current, simple, or standardized way of doing this. Our proposed apparatus, Immunocyte, could provide a simple and effective means of providing localized radiation therapy, including brachytherapy and immunotherapy. This technology is obviously a medical device, specifically delivering therapeutic agents to tumor tissue while avoiding or minimizing exposure of normal tissue to those agents. The concept consists of using a hollow tube-like structure to guide administration of the therapy, including radiation therapy, immunotherapy agents, and potentially cellular-based therapies to tumor sites. In the case of brachytherapy, a wire would serve both as a guide to feed this to the tumor, as well as a means to control radiation exposure within the tumor itself. Other therapeutic agents could be injected via a separate catheter through this hollow tube to the tumor site and allow to permeate locally through and around the tumor tissue from multiple openings in the tube is aligned within or in close proximity to the tumor itself. Here you see a schematic from the patent, which shows the ability of this device to deliver unique systemic agents and a variety of systemic agents while utilizing brachytherapy approaches. Now, is this a useful strategy? Well, it's believed to have a huge market potential. In 2021, over 248,000 men were expected to be diagnosed with prostate cancer in the United States, with 90% of those having localized disease, of which radiation therapy is a suggested treatment option. For other kinds of cancers that we've used radiation in brachytherapy approaches, like soft tissue sarcoma, there's over 13,000 cases, of which 60% of those would be localized, and many of which are going to receive radiation therapy. Indeed, with radiation being considered a strong inducer of the body's anti-cancer immune response, but without a current definitive strategy and currently great debate over the most effective way to synergize the potential of both RT and anti-cancer immunomodulating agents, which won't be effective in all patients as monotherapy. This is an exciting approach, thus, to try to create synergy. Currently, FDA-approved prostate cancer immunotherapy, Provenge, is administered systemically, improves patient median survival by only 4 months as a monotherapy, and costs $93,000 a course, indicating a need for improved modalities that can be given synergistically. The brachytherapy market in the United States was valued at approximately $370 million in 2018, expected to reach over $500 million by the year 2026. Brachytherapy is used currently for a variety of cancers, including prostate, cervical, or breast. In summary, this exciting U.S. patent brings the combination of therapies for administering both brachytherapy approaches with systemic agents to cancerous tumors. And this exciting Immunocyte catheter may be able to deliver radiation and additional therapeutic agents with a significant synergistic benefit. With that, I think this talk has opened as many questions as it has answers, and I look forward to bringing further developments to you in the future. Thanks again for the IPCU for allowing me to speak here today.